Sotatercept in high-risk patients with pulmonary arterial hypertension, the ZENITH study. So pulmonary arterial hypertension pathobiology is driven by pulmonary vascular remodeling. Here you can see a normal pulmonary vessel, which has a thin wall. It has elasticity and normal patency. On the right, you see a pulmonary artery in a patient with pulmonary artery hypertension. In this rigid, obstructed vessel with luminal narrowing, the pressure and resistance is increased, imposing a mechanical burden on the right ventricle. Part of the reason for this remodeling, which involves pulmonary endothelial and smooth muscle proliferation, as well as sustained inflammation, is due to an imbalance between pro-proliferative pathways driven by activins and anti-proliferative pathways driven by BMPs. This activin overdrive results in a breach of pulmonary vascular homeostasis with promotion of proliferation, and therefore the excess activin is a target of drug development to treat pulmonary arterial hypertension. Sotatercept is the first in-class activin signaling inhibitor approved for pulmonary hypertension. It is a biologic made of human IgG1 and the extracellular part of the activin receptor type 2A, which will act as a ligand trapped. So it's designed to rebalance the anti-proliferative and pro-proliferative signaling. Furthermore, it may result in reverse remodeling. In animal models, there is some regression of the disease because the endothelial cells and smooth muscle cells, which obliterate the lumen, go into apoptosis. The Phase 3 STELLAR trial showed that as add-on therapy in patients with pulmonary arterial hypertension, functional class 2 and 3, sotatercept significantly improved exercise capacity, and there was a reduction of clinical worsening with a good safety profile. However, it remains unknown if sotatercept can reduce the rates of mortality in major morbidity events. 172 patients were randomized in an intention-to-treat analysis, 86 on sotatercept and 86 to placebo. Functional class 3 or 4 at high risk of mortality were included, who were on maximal PAH therapy. It was an event-driven study. The patients were mostly female, average age in the mid-50s. These were World Health Organization Group 1, mostly idiopathic, with about 25% associated connective tissue disease, mostly scleroderma. 3/4 were functional class 3 and 1/4 was functional class 4. Regarding background therapy, 60% were on prostacyclin infusion, and all patients were on either double or triple therapy. Despite maximal therapy, the 6-minute walk test was only 270 meters, with NT-proBNPs around 3,000, and elevated PVR and mean pulmonary arterial pressures. This is a result of the primary endpoint. The primary endpoint was time to first event of all-cause death, lung transplantation, or PAH worsening-related hospitalization. As you can see, sotatercept significantly reduced the relative risk of morbidity and mortality by 76% versus placebo. The curve separated very early. The p-value was less than 0.0001. This was an interim analysis. It crossed the predefined efficacy boundary, prompting early termination of the trial. The components of the primary endpoint as standalone outcomes favored sotatercept with all-cause death, lung transplantation, and hospitalization related to PAH. In the predefined subgroup analysis, sotatercept demonstrated consistent benefits across all pre-specified subgroups, with all hazard ratios favoring sotatercept treatment, including PAH subtype, including functional class for patients, prostacyclin infusion, and very high PVRs. The secondary endpoints were tested in a hierarchical order, starting with overall survival. Overall survival did not meet the significance threshold at interim analysis. However, the hazard ratio showed a reduction of 58% in mortality, and the transplant-free survival endpoint was diminished by 66%. Other secondary endpoints were improved, including NT-proBNP, pulmonary resistance, and functional class. In terms of safety, adverse events leading to discontinuation were more common in the placebo arm. Adverse events leading to death were more common in the placebo arm. Severe and serious events were more common in the placebo arm. Bleeding was the most common side effect. It occurred in 62% of patients with sotatercept and 35% of patients in placebo. This was mostly epistaxis. Serious bleeding was about the same in both groups. Cardiac events were more common with placebo, and telangiectasia was more common with sotatercept. So in conclusion, ZENITH is the first pulmonary artery hypertension study designed to assess major morbidity or mortality-related events, and is the first to be stopped early at a pre-specified interim analysis for efficacy. Sotatercept significantly reduced the composite of all-cause death, lung transplantation, and pulmonary arterial hypertension worsening related hospitalization in patients with advanced pulmonary arterial hypertension. Safety and tolerability were generally consistent with previous studies.